Hello and welcome to my YouTube channel. My name is Dr. Sayed Kazmi and today we'll be focusing on complex regional pain syndrome right here on this channel. So stay tuned. So let's talk about the complex regional pain syndrome, or CRPS as it's commonly known. So CRPS is basically a sustained sympathetic activity in a perpetuated reflex arc characterized by pain out of proportion to physical findings. Now, what does this all mean? This basically means that usually after an injury, which could be just a somatic injury or sometimes really could be a nerve injury as well, after that, there is a sustained, means that there is something which is continuously ongoing overactivation of the sympathetic chain of the autonomic nervous system in a way that it's constantly being activated. And what it leads to? It leads to certain chemical changes at the ends of these neurons coming out of the autonomic nervous system, which leads to a perpetual sensation of pain and certain other autonomic phenomena like swelling, like color changes and vasomotor changes, which are usually out of proportion to physical exam findings. In other words, it means that the original precipitating injury might be a minor one, but the after effects are such that they do not tally. Like, for example, somebody having a minor injury to the ankle or the lower leg, which should ideally resolve within 5 to 7 days, that continues for months, and the pain is so severe that sometimes the patient can be almost like next to be being disabled because he cannot do his normal routine activities, might be bed bound or might be wheelchair bound. So basically an overactivation of the autonomic nervous system leading to certain changes, and these changes leads to pain and other findings which are out of the proportion to the original injury or to the physical examination findings. Now, in the past, it used to be called as reflex sympathetic dystrophy. This was a traditional term which has been used in many books in the past, but these days it is known as complex regional pain syndrome. It's known as complex because there are so many things in that which are very poorly understood. So it's a very complex phenomena. And these days, this CRPS, complex regional pain syndrome, is divided in two parts: CRPS type 1 and CRPS type 2. So CRPS type 1 usually occurs after somatic injuries, like usually soft tissue injuries or maybe even like fractures or something. And the other type, that is the type 2, usually is caused by nerve injuries. So these nerve injuries could be because of anything. Usually most of the time it could be trauma. And it used to be called, in the past it used to be called causalgia, but nowadays it's known as CRPS type 2. Now a little bit about the historical background of CRPS. Now, somewhere back in the 18th century, Weir Mitchell, he actually described the phenomena, which was bizarre symptoms after the soldiers who were taking part in the American Civil Wars. They developed certain symptomatology after, like, the gunshot wounds which happened to them, and they were very bizarre symptoms. Like it was like pain and other types of symptoms which could not be explained by certain pathological processes, and that's why it was given the term causalgia for this type of pain. Then later in the earlier 20th century, Peter Sudak, he further worked on that, and he described the features of pain, swelling, and atrophy, muscle atrophy following minor injury to the limb. And then it was known as the reflex sympathetic dystrophy because of its association with the sympathetic nervous system. So they said in some form there's a reflex overactivation of the sympathetic autonomic nervous system, which leads to certain changes, which leads to all these bizarre symptomatology after trauma. And nowadays, in the 21st century, we call it as the CRPS, or complex regional pain syndrome. Now, as far as the epidemiology is concerned, usually it's more common in younger people and more common in females as compared to the males. Like we say, that's probably 2 to 3 times more common in females as compared to the males. And usually it is more common after limb injuries. So upper limb injury and lower limb injuries are one of the most common areas where people complain of this bizarre symptomatology, which is known as complex regional pain syndrome. Then a little bit about the mechanism of reflex sympathetic dystrophy, or CRPS as it is called these days. So what happens usually, the inciting agent is trauma, and in most of the cases the trauma is a minor trauma. So it could be just like, somebody bumps into a hard surface, gets bruising or gets a sprain of the wrist, of the ankle, of the knee, could be any part of the limb. So initially the inciting factor is always an injury. So what happens after the injury? You know that whenever there is an injury to any part of the body, so the pain sensations are carried to the brain, and from there then there certain neurotransmitters are released, and these neurotransmitters give you the sensation of pain. And then because of the pain, what you do is normally you don't move that particular part, and it helps in the regeneration of the damaged tissue, which helps in the healing process. Now what happens is that in case of the CRPS, there is a sort of a permanent activation of the autonomic nervous system, the sympathetic chain, which is running parallel to the spinal cord, that gets activated, and normally does get activated, but this is a sort of a temporary activation. So it would activate in response to the initial painful phenomena. It would release certain neurotransmitters, and those neurotransmitters would cause certain changes at the site of the injury. For example, certain types of cytokines, certain types of chemicals would be released that would increase the blood flow in that area, that would lead to inflammation, that would help in the healing process. But in this, what happens, the sympathetic chain is actually activated in such a way that it leads to a constant release of certain chemicals, which could be cytokines, which could be interleukins, which could be neurotransmitters, which cause certain strange changes. And these changes could be vasomotor, in which the blood vessels to the area might get constricted, and this constriction might lead to altered discoloration. They might lead to perpetual activation of the nerve fibers, which leads to allodynia, hyperalgesia, where a person feels even pain with the very light touch, or there's a constant like sensation of pain going in that particular area. It can also lead to certain changes in the blood vessels, which can sometimes lead to opening of the blood vessels, which leads to edema in that area. And it could also lead in a long term, the area which is which is affected might the bones in that area might become weak over a period of time because of osteopenic changes, again, which are manifested by this sympathetic nervous system. So this is basically the overactivation of the sympathetic nervous system. Why it happens, we don't know. In many people it doesn't happen, but in some people it can happen. So it's very poorly understood why there would be an overactivation of the sympathetic nervous system, leading to all these changes, which would cause like perpetual pain, which would cause like changes in the vasomotor phenomena, which would lead to swelling, which would lead to color changes, which might lead to sweating in that particular area, abnormal sweating, so on and so forth. Then the type of changes that occurs because of this sympathetic overactivation of the autonomic nervous system. So they can have like some autonomic phenomena, which means that they can have skin color changes. The skin they usually report that the skin becomes bluish or purplish. They might report that that particular area is sweating, or it's not sweating. So it might be very cold, because the skin temperature goes up and down depending on the vasomotor phenomena. So sometimes there could be vasoconstriction leading to bluish discoloration and cold sensation, because less blood flow is going into that area. Or sometimes it could be more swelling in that particular area because of the opening of the blood vessels, and it might feel more hot as compared to the rest of the body. So these like up and downs because of the up and down phenomena in the autonomic nervous system can cause these symptomatology. Similarly, they can have like sensory changes, and these sensory changes can be allodynia. So like even small impulses which should not cause pain, even they start like causing pain. It could be hyperalgesia, hyperesthesia, hyperpathy, and hypoesthesia. So that could be different combinations. Sometimes there is more pain, sometimes it feels numb. So that area feels numb. You feel like you can't feel it. So if you ask the patient that if you touch the opposite side as compared to this side, they would say the opposite side feels more as compared to the affected side, which feels more numb. So it could be either like where they feel more pain, hyperalgesia, or it might be hypoesthesia, where they're not feeling much pain and feels more of numbness in that particular area. They can also have like motor phenomena like subjective like weakness, tremors, dystonia, myoclonus can occur in the area which was injured. Similarly, they can have inflammatory or trophic changes, which can mean abnormal hair growth, abnormal nail changes in the particular area, or even like skin changes. So the skin becomes thinned, or the skin becomes even like thickened as well. And it can be associated with psychological phenomena. So obviously, these people have got they've got anxiety. They can suffer depression because of this ongoing issues, and then sometimes they are not able to cope with their daily life stresses because of this phenomenon, and they can have behavioral issues as well. So you see that this CRPS, complex regional pain syndrome, can have a myriad of different symptoms and signs which you can find in that particular person who has suffered even a minor trauma, and after some time they don't get better, rather they become worse, and the symptomatology goes on and on and on. And these are the people who you have tried painkillers and everything on them, and in most of the cases things are not working. And as I told you, based on the epidemiology, it's more common in younger people, and female are more prone to develop CRPS as compared to the males. Now here you can see the swelling and the color changes. So if you see this diagram, so you can see the right upper limb seems normal, but the left upper limb seems to be swollen and edematous. Here you can see another picture where the wrist seems swollen, though this injury might be a minor injury and might have occurred months ago, but you can see the swelling is still there. So this is all because of perpetuated abnormal sympathetic overactivation of the autonomic nervous system. Moving on, here is another image. You can see the same changes in the lower limbs. Then you can see this is the palm of a person who has got a lot of sweating, and you can see a scar as well. There might be some injury in that the wrist, might be a laceration or something, but now you can see that there are trophic changes. There is abnormal sweating in this particular area, while the rest of the body hasn't got any abnormal sweating. So again, this is part of the CRPS. So the stages of the CRPS. So again, it is acute, it could be subacute and chronic. So acute changes usually occurs immediately in the time period after the injury. The subacute changes occur after some months, and chronic are usually after a year. So talking about that, acute changes are those changes which start appearing within 0 to 3 months of the initial injury. And the common exam findings of CRPS in these, they complain of ongoing pain, they complain of ongoing swelling, they complain of ongoing warmth or redness, sometimes decreased range of motion, and hyperhidrosis, which mean increased sweating in the area which suffered the injury. So usually if you do the imaging, because these people, they come to the ED departments, and again most of the doctors, they are tempted to do x-rays again and again to see whether there is any other fracture which has been missed or something. But you would see that in most of the cases, repeat x-rays are always normal, because the injury is usually, in most of the cases, the injury is healed by this time, or the injury was a very minor one. And usually if you do the three-phase bone scan, it's usually positive. I will come to that later on. Subacute changes usually occur between 3 months to 1 year. And what happens is that by this time, their pain has even worsened as compared. So the history would be a worsening pain. Usually they start complaining of bluish in the corresponding limb. They complain of dry skin, like the trophic changes, stiffness, and skin atrophy. And usually by this time, if you do their x-ray, you would see that the bones have started becoming osteopenic. In other words, like the calcium has started mobilizing from the bone. So these bones become a bit less dense, which you call as osteopenia, because the calcium is being mobilized and the bones become more soft. While chronic changes occurs after a year. And what happens in this particular phase, now after some time, like what happens, the pain starts going down. So as compared to the previous, they say now the pain has gone down, but you might see that the area has become a bit of fibrotic, the skin is a bit glossy, and they might have developed joint contractions, because by this time the chronic changes, coupled by the fact that they may not be mobilizing much, like the concerned joints might not be mobilized much, leads to contractures. So usually you would be finding some form of joint contractures at this particular age. And if you do an x-ray, again, you're not going to find fractures, something. You're going to find severe osteopenia, that the bone would be very, very less dense, because the calcium has been mobilized. So it's got 3 phases: acute, subacute, and chronic, that you should remember. Now, as far as the International Association for Study of Pain Classification, that is IASP. So IASP divides them into two types, type 1 and type 2. So type 1 is the complex regional pain syndrome without demonstrable nerve lesion. So usually what happens, these are minor injuries which do not lead to any trauma to the nerve. So the nerve ends are not severe. There's no nerve injury. So, and this happens because of, like, simple trauma, like, bumps and bruises. Sometimes it can happen after tight casting or a tight bandage. While type 2, basically there is a demonstrable nerve damage. So basically in that particular injury, the nerve was severed or the nerve was crushed. So usually if some form of nerve conduction studies are done or other modalities are done to localize nerve damage, they usually are positive for nerve damage. So usually in this case, what happens that there is a demonstrable nerve lesion, and that nerve lesion, as it heals, that can lead to certain types of changes, which again we call it as CRPS type 2, and it is less common. Okay, moving on. Differential diagnosis. Now, not everybody can be put into bracket of CRPS. Remember, it's a diagnosis of exclusion, and there's a criteria. I will come to that later on. There's a Budapest criteria for the diagnosis of CRPS, but it's important to differentially diagnose it from, like, people who have got diabetic. They might have diabetic neuropathy. So diabetic neuropathies are very common. These are mononeuropathies, and in a particular area, like for example in the wrist or something, the nerve might not be working. So you might think that this is complex regional pain syndrome, though in fact there is an underlying diabetes, and that diabetic mononeuropathy is actually causing the reflex changes, sympathetic changes. So remember, diabetes is very common, so you have to ensure that the person is not diabetic. Similarly, entrapment neuropathies. Entrapment neuropathies happens, like for example carpal tunnel syndrome or something, where people have got some edema or localized fibrosis of the limbs, where the nerves can entrap, and when the nerves entrap, that can give you abnormal signals, and that can lead to pain, which is very much like similar to complex regional pain syndrome. So again, that is another differential diagnosis that should be kept in mind. In case of upper limb pain, you should be familiar with thoracic outlet syndrome, or sometimes they can have an extra rib, a cervical rib, which can impinge on the brachial plexus, and that can give pain to in the corresponding area of those nerves. Similar discogenic disease, in which there is a disc problem in the cervical disc or in the lumbar disc. So what would happen is that it would impinge on the nerve fibers, like for example sciatic and the lower limb, like where the pain shoots down right from the hip down to the little toe. So again, you have to exclude that as well. Make sure that that is including your differential diagnosis. Deep vein thrombosis, yes, in female, especially in lower limbs, somebody who's complaining of pain or swelling even after injury, because after injury, some of the people who have got like coagulopathies and they're not mobilizing much, they can develop deep vein thrombosis. Very important that you consider that in the differential diagnosis. Probably a Doppler study would be the best thing to rule out DVT. Cellulitis can happen because of the soft tissue infection, pretty much self-explanatory. Vascular insufficiency can occur because of certain reasons that would lead to edema of the dependent region. It's usually a bilateral condition. Similarly, lymphedema, isolated lymphedema or bilateral lymphedema again can cause these things, though rarely. Or erythromelalgia, which is actually a rare disorder which is characterized by burning pain, redness in the extremities. So these are some of the differential diagnoses we should keep in mind. But remember, the most important is diabetic neuropathy. So diabetic neuropathy, DVT, these are the two things which you should never miss, especially DVT, because DVT can have fatal consequences. So remember, if a female comes, especially if she's obese, and if you think that she's taking oral contraceptive pill, and even if she had a history of injury in the past and now is complaining of swelling, pain and numbness, remember, it's important, before you label somebody with CRPS, you should rule out DVT. Very, very, very important. Then moving on, as far as imaging is concerned, because there is a tendency to do repeat imaging in these people because of the ongoing pain in the limbs. Remember, the images usually they do not demonstrate any x-rays, any fractures, but they do demonstrate over a period of time that the bones, they become weak, and the bones, because the calcium is being mobilized, so we call it osteopenia. Three-phase bone scan, in which the bones scan is done in three phases. That is sometimes done to rule out a complex regional pain syndrome, though it's got a low positive predictive value, but it's got a high negative predictive value. So for example, if it is negative, then you can rule out complex regional pain syndrome, but if it is positive, it can be because of a different reason, not necessarily CRPS. Then infrared thermography, which is used to be done, but it's of questionable utility, not done anymore. Electromyography and nerve conduction studies might show a little bit of like slowing in the along the length of the nerves, but again, they are not very much specific because they can happen in different types of disease, like demyelinating disorders and different types of muscle disorders. Obviously, EMGs and NCVs would be affected. Then as far as prevention is concerned, remember, like, the best thing would be to prevent injuries, but usually that's not possible. So they say those people who are taking vitamin C 500 milligram dailies for 50 days in distal radial fractures. This was a study which was done, and they were treated conservatively. They found out that the chances of CRPS in those people was low. Similarly, if these people have got impaired renal function, then the vitamin C dosage can be reduced down to 200 milligrams. So vitamin C 500 or 200 milligram, depending on the state of the person, is a good thing, which has been shown to decrease the incidence of the type 1 CRPS following foot and ankle surgery. So those people who have undergone surgeries and they have later developed CRPS, it has been shown by studies that those people who were given 500 milligram for 50 days, the incidence of the CRPS was quite low. Similarly, it's important, those people who are undergoing surgery or who have got minor injuries, do not put them in splints. Like, there is always a tendency, if somebody comes and they say, oh, I've got a lot of pain, and the x-rays are usually negative, and they say, give us something. So, like, putting them in a cast or a boot or a splint, it should not be done, because the more you immobilize it, you are increasing the chances of this CRPS in the future. So that's why they should have like proper painkillers, good analgesia, and they should mobilize as soon as possible. That's the key of any minor trauma management. Then treatment is like, it's all about rehabilitation, pain management, psychological treatment, because it's very complex. So one thing doesn't work, and it's usually multidisciplinary, because they will require some form of physiotherapy because they're not moving their limbs, and obviously with the passage of time the muscles become weak, so some form of physiotherapy is needed. They may even develop joint contractions, so again, more important, physiotherapy. Similarly, medical team, from the point that they can give them certain types of medications, neuropathic medications, like, which modulate the the conduction along the nerves, like pregabalin or gabalin or things like that, drugs which can be used in neuropathic pain. Similarly, psychological treatment is also important. These people are suffering some form of depression, or they may have got the tendency to develop depression or behavioral issues, or they might be, usually most of these people have got, are those people who have got an underlying issue of anxiety as well. So to treat that simultaneously at the same time is also very, very important. Then as far as rehabilitation is concerned, rehabilitation, usually it means like they should be mobilized as soon as possible. They should not be like, bedridden or wheelchair bound. There are different types of exercises like isometric and isokinetic. Isometric exercises are those exercises in which the joint is not moved, but there is sustained muscle contraction without moving the joint. So isometric exercising, isometric strengthening of the muscle exercises should be done. Stress loading. Then isotonic strengthening. Isotonic strengthening is that where you are actually moving the joint, and different range of movements should be gradually introduced along the affected joint, so that the patient improves over a period of time. And similarly, postural normalization and aerobic conditioner, where the personal posture and aerobic condition, like, so like they are doing exercises in which like they take a lot of oxygen, and the sort of aerobic conditioning of the body. It's a general term, where you do exercises which require a lot of like breathing exercise and things, and that improves your general body response to different types of stresses. So that should be done. Similarly, some of the pharmacological medication that can be done, these are GABA agonists, IV alendronate or bisphosphonates can be used. Calcium channel blockers have been used. Antidepressant have been used. Non-steroidal anti-inflammatory. Remember, these are the drugs which are basically on the discretion of the physician. There is no single formula that what drug needs to be given. Depends. Some drugs work in one group of patients, some drugs work in another group of patients. So they're not hard and fast rule. It's just like trial and error. And some of the minimal invasive therapies like sympathetic blocks, regional blocks, so epidural infusion of painkillers, these are like, therapies which would be given in extreme cases. These are not something which is given on a usual, but like, a very small percentage of patients which have got like severe debilitating CRPS. There, these things can be tried. Some more invasive therapy are neuro augmentation, like where the nerves can be transplanted, spinal cord stimulation by electrical circuits, or intrathecal delivery of certain types of medication. These are again more invasive therapies which are done in specialized centers, not used routinely. And last but not the least, sympathetic. If everything fails, the sympathetic nervous system, like those areas from where the impulses are coming, they can be transected, but then they've got their own side effects. So sympathetic will be done, but again, it's a very controversial process, not routinely done. And if it might be done if there is no other choice left, and worst comes to worst. So this was all about uh, complex regional pain syndrome. Remember, prognosis is difficult to predict. Early interventions are more likely to be successful. So the early you treat them, the better the outcomes. But nevertheless, it's still a disease which is considered to be an enigma caused by abnormal sympathetic reflex activation. And the thing is that different medications are tried, but the outcomes are not that much successful. So if you've got any questions or queries, put it down in the comment section below, and I will try my level best to get back to you and answer those things. Have a very good day, and bye bye.